Okay. Thank you so much, Dr. Rastogi. I really appreciate that you invited me to participate in this symposium on kidney stones. It's really an honor for me to be here and to share the stage with my esteemed colleagues and friends, David Goldfarb and John Lesky. Over the last few hours, you've heard extensively and quite eloquently on the pathophysiology, genetics, and prevention of kidney stones. And what I'd like to focus on during my talk is how we actually manage patients who have stones. And to that end, I'm going to divide my talk into management of the acute symptomatic stone event, the dilemma of what to do with patients with asymptomatic, non-obstructing calyceal stones, and I'd like to share with you some of the current evidence on surgical management of kidney stones. So for any patient who presents with a presumably acutely passing stone, classic symptoms of renal colic can certainly suggest the diagnosis, but radiographic imaging is really the cornerstone of the diagnosis of cornerstone in the diagnosis of patients with an acute kidney stone. And there are a number of imaging modalities that can be used to diagnose kidney stones with varying sensitivity and specificity, but CT by far has the highest sensitivity and specificity for diagnosing stones, and along with its wide availability, its fast acquisition time, and the ability to identify stones of all compositions, has made it the imaging modality of choice in the evaluation of patients with acute flank pain and suspected ureteral calculi. Unfortunately, CT is associated with a significant amount of ionizing radiation, and for patients with recurrent kidney stones, the use of CT imaging over time can lead to substantial radiation exposure. And as a result, some investigators have turned back the hands of time to some degree and have recommended going back to ultrasound imaging as first-line management for patients with suspected ureteral stones. Smith-Binman and colleagues performed a large, highly publicized, multi-center trial in which over nearly 3,000 patients with flank or abdominal pain and a suspected stone were randomized to either a point-of-care ultrasound, a radiologist-directed ultrasound, or a non-contrast CT scan, and patients were then followed for 180 days and contacted at various time points to assess their outcomes. The primary outcome parameter in this study was a 30-day incidence of a high-risk diagnosis with a complication related to either a missed or delayed diagnosis, such as a ruptured abdominal aortic aneurysm or diverticulitis with abscess or sepsis. And a second primary outcome parameter is cumulative radiation exposure up to 180 days. So what they found is that overall, the incidence of a high-risk diagnosis associated with a complication was relatively low in all three groups, and there was no statistically significant difference between the three groups. In addition, radiation exposure, both overall and the radiation exposure just in the emergency department, not surprisingly, was significantly lower in the ultrasound groups compared to the CT group. They also found no significant difference in secondary outcome parameters between groups, including serious adverse events, 7-day visual analog pain scales, return to the emergency department, or hospitalizations. So these authors suggested that ultrasound should be the initial imaging modality of choice in patients with a suspected passing stone. However, using ultrasound as the initial imaging modality does potentially lose important information about stone size, stone location, and prognosis, at least until further evaluation, perhaps with further imaging studies. And in fact, these authors ultimately performed a second study and published a second study in which they looked at 143 patients who ultimately underwent a procedure for stones after that initial emergency department visit, and more than 3/4 of those patients underwent CT imaging before intervention. So what did we learn from this trial? Well, I think we learned that in recurrent stone formers with classic symptoms, ultrasound, at least along with a KUB, could constitute first-line imaging. And for those patients without a history of stones, or for those who present without classic symptoms, then a low-dose CT, that is a CT associated with reduced radiation exposure that preserves the sensitivity of a standard dose CT, can be used as first-line imaging. Now, after the diagnosis of a stone, the goal is really to relieve pain. And we know that narcotic analgesics are effective in relieving pain, but they are associated with side effects. And there's been certainly recent concern about the risk for abuse or addiction. On the other hand, NSAIDs are highly effective. They have few side effects, but it is important to watch for contraindications related to gastrointestinal bleeds or compromise of renal function. Pathan and colleagues performed a meta-analysis of 36 randomized trials comprising nearly 5,000 patients, comparing NSAIDs versus opioids in patients with renal colic. And they found a marginal benefit of NSAIDs over opioids for initial pain reduction, and furthermore found that NSAIDs were less likely to require rescue medication for recurrent pain, and the NSAID arm had fewer episodes of vomiting, suggesting that NSAIDs should constitute first-line analgesics in patients presenting with an acute stone event. Now, probably the most commonly recommended treatment for the management of a patient with an acutely passing stone is to push fluids. And there are actually two trials, randomized trials, that evaluated the benefit of a high versus normal fluid intake in reducing the need for surgery or pain. Both of these studies randomized patients to either receiving no fluids or minimal fluids versus 2 liters of fluids over a 4 or 6 hour period of time. Both studies showed that there was no significant difference in pain scores, need for surgical intervention, or spontaneous passage rates in the two groups, suggesting that there's no evidence to support the practice of forced fluids, and maintenance fluids, or at least resuscitation to euvolemia, should be sufficient in most cases. So the next question then is, when do we intervene, and who do we need to admit to the hospital? Well, no intervention is necessary if a stone is likely to pass, if the pain is well controlled, if there's minimal or mild obstruction, and if there's no associated signs of infection. On the other hand, intervention, or at least admission and observation, is warranted when the stone fails to or is unlikely to pass in a patient who's experiencing unremitting pain, unresponsive to pain medication, if a patient has high-grade or persistent obstruction, if there are signs of infection, or in patients who have an anatomically or functionally solitary kidney. One of the tenets in urologic surgery is that obstruction associated with infection mandates prompt surgical drainage of the collecting system. And there's actually some recent administrative data sets that actually support that tenet. Borofsky and colleagues used the nationwide inpatient sample and identified 1,712 patients with a diagnosis of ureteral calculi and either SIRS or septic shock. Among this group of patients, 90% survived their hospital admission, while 10 of them succumbed to death. When they stratified patients according to whether or not they underwent drainage or decompression of the collecting system versus no decompression, they found that 8.8% of the patients who underwent decompression ultimately expired, compared to 19.2% of patients who expired who did not undergo decompression, suggesting that mortality rates are higher when the kidney is not drained. More recently, Oja Shah's group used an updated nationwide inpatient sample and identified over 311,000 adult patients with a diagnosis of urinary tract infection and renal ureteral calculi with hydronephrosis, and performed multivariable logistic regression analysis to identify predictors of death. They found that after controlling for patient demographics, comorbidity, and severity of disease, delayed decompression, that is decompression that took place more than 2 days after admission, was associated with a 29% higher mortality rate compared to early decompression after admission, again, suggesting that prompt decompression of the collecting system is mandatory. There are remaining questions in considering patients with obstruction and signs of infection. How do we identify those who need to undergo draining? In other words, what parameters and what threshold values of those parameters can predict infection? We can look at parameters like heart rate, white count, temperature, procalcitonin levels, or the urinalysis, but we don't know what cut points to use. And also, can we predict who will actually progress to septic shock after they undergo drainage of the collecting system? Now, for patients who have ureteral stones, we know that the more distal the stone is located in the ureter, the more likely the stone is to pass spontaneously. And we also know that spontaneous passage rates vary inversely with stone size, so that overall about 50% of ureteral stones will pass spontaneously. But recently, there have been a number of randomized trials that have suggested the ability of some drugs, primarily alpha blockers and perhaps calcium channel blockers, to promote the spontaneous stone passage of ureteral stones. And they're thought to act by either relaxing ureteral smooth muscle or producing a more coordinated contraction of the ureter to help promote passage of the stones. There are a large number of randomized trials that have compared medical expulsive therapy with placebo or no treatment control groups, and most of these trials have shown a benefit of therapy, but there have been a number of recent large high-profile trials that showed no benefit of therapy or showed a benefit of therapy only in certain subgroups of patients. Locke and colleagues performed a recent meta-analysis of 67 randomized trials comprising over 10,000 patients with 10 millimeter or less ureteral stones and comparing alpha blockers with a placebo or no treatment control group. Alpha blockers were associated with a higher stone clearance rate, a shorter time to stone expulsion, fewer hospitalizations, and less need for pain medication, although no significant difference in need for surgical intervention was found between the two groups. They also found greater efficacy in larger, that is greater than 5 millimeter stones compared to patients who had 5 millimeter or less stones. And although they found efficacy for patients with stones in the distal ureter, that didn't hold true for stones in the mid or proximal ureter. So is medical expulsive therapy beneficial? Well, probably, I think, at least for larger distal ureteral stones, but I think it is important to inform patients that this is an off-label use of the drug and that there is some conflicting evidence in the data. So in conclusion, for the first part of this talk, CT imaging is the imaging modality of choice for first-time stone formers with suspected ureteral calculi, but ultrasound and KUB can be used in select recurrent stone formers. NSAIDs constitute the best first-line analgesics in patients with an acute stone, and forced fluids are not recommended in this setting. Patients with obstructing stones and signs of infection should undergo prompt drainage of the collecting system. And finally, medical expulsive therapy is optional, but it may be advantageous, at least in patients with larger distal ureteral stones. Now, more controversial is how to manage the patient with an asymptomatic, non-obstructing calyceal stone. Treating patients avoids the morbidity of the acute stone event, but it may be that that stone will never become symptomatic. There are a number of studies that have looked at the natural history of asymptomatic renal calculi, and that's information we need to be able to properly counsel patients regarding management of their asymptomatic stone. And these studies vary according to the mean size of the stone, the follow-up, and the different parameters that are followed, the need for surgery, the symptomatic stone event, or spontaneous passage. One of the more recent studies, which is one of the larger studies with among the longer follow-up, is a study by Durad and colleagues in which they looked at 301 renal units and 238 patients, in which the cumulative stone size was 10.8 millimeters. At a mean follow-up of 63 months, they found that the majority of patients were able to remain on active surveillance. 59% of patients remained on surveillance, while 27% of patients required surgical intervention for progression of their stones or for the symptoms. 15% of them spontaneously passed their stone, and overall, 39.5% of patients experienced a stone-related adverse event. On multivariate analysis, they found that younger patients greater than 50 years of age and patients with stone growth greater than 1 millimeter per year were associated with an adverse event. But can we give our patients more information? Can we identify those patients who are more likely to fail conservative therapy? Well, unfortunately, there really is no uniformity of data, and analysis of the effect of stone size, stone location, and patient characteristic has been conflicting, and we haven't been able to come to any uniform consensus. So conservative management of asymptomatic non-obstructing stones is reasonable, but it should be a shared decision with the patient. Unfortunately, attempts to identify subgroups of patients at higher risk of failing observation have yielded conflicting results, and that makes individualized decision-making somewhat difficult. Now, for patients who need to undergo surgical or intervention for their stones, almost all stones can be managed in a minimally invasive or non-invasive fashion with either shockwave lithotripsy, ureteroscopy, or percutaneous nephrolithotomy. Unfortunately, over the last few decades, lithotripsy technology has been disappointingly stagnant, while at the same time, there have been substantial advances in technology and technique that have expanded the role of endoscopy for the management of upper tract stones. And while the focus has been on ureteroscopy as sort of the treatment du jour, Pcnl is really the procedure that's associated with the highest stone-free rates, but it also has the highest morbidity. Orden and colleagues used administrative data sets in the province of Ontario to perform a population-based cross-sectional time series analysis looking at trends in the distribution of surgical stone procedures over a 2-decade period of time. They found that shockwave lithotripsy significantly decreased in its proportion of surgical stone procedures, while the proportion of patients treated with ureteroscopy correspondingly increased, with a crossover occurring at around 2004. Pcnl is the least utilized procedure, comprising only about 5 to 6% of procedures, and that has remained relatively stable over time. Through the years, we've had the benefit of learning the limitations of shockwave lithotripsy and being able to refine our indications for shockwave lithotripsy. We've learned that with increasing stone size, shockwave lithotripsy stone-free rates decrease, retreatment rates increase, the need for ancillary procedure increases, and complication rates increase. We also know that if we stratify stone-free rates according to stone location, the highest stone-free rates occur for stones located in the renal pelvis or ureteropelvic junction, followed by the upper pole, the mid pole, and by far the lowest stone-free rates occur in stones located in the lower pole of the kidney, likely because of the gravity-dependent location of the lower pole calyces. James Lingemann was the first to recognize the limitation of shockwave lithotripsy for stones located in the lower pole of the kidney, and he convened a multi-center randomized trial comparing shockwave lithotripsy with percutaneous nephrolithotomy for isolated lower pole stones. The primary outcome parameter in this study was stone-free status determined by nephrotomograms. He found that when stone-free rates were stratified by stone location, you can see that the stone-free rates for Pcnl, shown in pink, were uniformly high regardless of stone size. On the other hand, stone-free rates for shockwave lithotripsy were highly size dependent and were really acceptable only for stones less than a centimeter in size, where the stone-free rates were 63%. And those stone-free rates were dismal for stones between 1 and 2 centimeters in size and greater than 2 centimeters in size at 23 and 14%, suggesting that shockwave lithotripsy is really acceptable only for less than 1 centimeter lower pole stones. And for stones greater than a centimeter in size, Pcnl is best. So the indications for shockwave lithotripsy for renal calculi would be less than 2 centimeter non-lower pole renal calculi, less than 1 centimeter lower pole renal calculi, and stones that are not shockwave resistant. So cystine stones are shockwave resistant and shouldn't be treated with shockwaves. And even calcium oxalate monohydrate and brushite are associated with poorer outcomes with shockwave lithotripsy, although unfortunately we often don't have the benefit of knowing a stone analysis prior to treatment. Now, on the other hand, ureteroscopy can be used for nearly all ureteral stones, and it can be used for moderate-sized renal calculi. The AUA Surgical Management of Kidney Stones guidelines compared shockwave lithotripsy and ureteroscopy for the treatment of ureteral stones and stratified stone-free rates according to stone size and stone location. They found that overall shockwave lithotripsy had the least morbidity and the lowest complication rate, but ureteroscopy had the highest stone-free rate in a single procedure. That's data that's also been validated by Bowen and colleagues in a recent population-based comparison of retreatment rates, comparing shockwave lithotripsy and ureteroscopy using an all-payer claims database from South Carolina. Among over 136,000 shockwave lithotripsy and ureteroscopy procedures, shockwave lithotripsy constituted 60% of procedures, and overall 10.4%, there was a 10.4% probability of undergoing a retreatment. Among the 40% of patients who were treated ureteroscopically, there was a 7.5% probability of retreatment, so that overall shockwave lithotripsy was associated with a 20% higher risk of retreatment compared with ureteroscopy. But ureteroscopy really isn't the panacea surgical procedure that many think it is. In fact, only recently have investigators begun to subject ureteroscopy to the scrutiny of CT imaging in determining stone-free rates. And we followed in the heels of several others who performed retrospective analyses and one prospective analysis evaluating ureteroscopy stone-free rates using CT imaging. We prospectively evaluated 167 patients with 209 renal units with renal ureteral calculi treated ureteroscopically. All patients underwent CT imaging pre and at 6 to 8 weeks postoperatively, and we made every effort during the procedure to actively manually retrieve all fragments left in the kidney. Our median aggregate stone size was 13 millimeters. Our mean operative time was 82 minutes. And we quantified the number of passes up and down the ureter to retrieve stone fragments, sort of as a surrogate for how meticulous we are in removing stone fragments. And our mean number of passes was 35.5, but you can see the range extended up to 240 passes, which is a long day at the office. We found that despite how careful we were at trying to remove all these fragments, our stone-free rate was disappointingly low at only 55%. We then stratified stone-free rates according to stone size and stone location to see if we could identify subgroups of patients who might be more successfully treated ureteroscopically. We found that stone-free rates in the ureter were reasonably good at 82%, but in the kidney, those stone-free rates were only 48%. It was really a coin toss if those patients were treated successfully. For stones less than a centimeter in size, that increased marginally to 62%, but for stones between 1 and 2 centimeters, the stone-free rates are fairly dismal at 39%. So patients really need to be selected for whom a stone-free state is achievable. But why is it that stone-free is so important? In other words, what are the long-term consequences of residual fragments? Well, we can look at the Shockwave lithotripsy literature to answer that question. And there are 5 trials in which they looked at the natural history of patients left with small residual fragments after Shockwave lithotripsy. There were 640 patients in these trials, and a mean follow-up of 34 months. 40% of patients developed a symptomatic event because of their residual fragment. And of those patients, 57% ultimately required surgical intervention. Rob Nadler also looked at the natural history of residual fragments after ureteroscopy and identified 46 patients left with 4 millimeter or less residual fragments after ureteroscopy. And they found that 19.6% of patients or renal units, that's nearly 1 in 5 patients, experienced a stone-related event at a mean of 1.6 years. And that includes 2/3 of patients who underwent repeat ureteroscopy and 1/3 of patients who required hospitalization for renal colic. Ryan Steinberg, when he was a fellow with us, also looked at the fate of residual fragments after ureteroscopy, looking at our prospective database of 226 renal units treated ureteroscopically who were imaged postoperatively with a CT. We identified 155 renal units and 130 patients who had at least 1 year of radiographic follow-up, and we compared the outcomes of the 88 patients left with residual fragments to the 67 patients who were rendered stone-free. Our primary outcome parameter was a stone-related event. So we found that a stone-related event occurred in almost half of the patients left with residual fragments versus only 15% of patients in the stone-free group. We also found that the median time to a stone event was 20 months in the residual fragment group, and it was twice as long, 42 months, in the patients in the stone-free group. We found by Kaplan-Meier analysis that the 24-month event-free survival was 70% in the renal units who were left with residual fragments versus 98% in the renal units who were left without residual fragments or rendered stone-free. So residual fragments, even small ones, have consequences. So if ureteroscopy yields unacceptably low stone-free rates for larger stones, should we lower the threshold for Pcnl? We know that the outcomes with Pcnl are excellent. In this study from John Densett's group and Hassan Razvi's group in London, Ontario, over 2,300 Pcnls were analyzed, including 1/3 of patients who had partial or complete staghorn calculi. The overall stone-free rate was quite respectable at 81.6%, and that increased to almost 91% with the use of second-look flexible nephroscopy. And the overall transfusion rate was only 1.4%, with a major complication rate of 2.3%. This is really the gold standard. Unfortunately, there's a reluctance on the part of practitioners to utilize Pcnl because of its higher morbidity, and that has led a number of investigators to progressively decrease the size of the nephrostomy tract and to introduce the so-called mini Pcnl. So why mini Pcnl? Well, the thought is if you reduce the size of the tract, you'll cause less damage of the kidney, resulting in less bleeding, less pain, and a shorter length of stay. The trade-off, of course, is that you can't remove large fragments or aspirate small fragments through a small tract, and it obviously takes a longer time to remove those fragments. Zhu and colleagues performed a meta-analysis of randomized trials comparing mini Pcnl with standard Pcnl and found that overall there was no significant difference in stone-free rates between the two groups. But mini Pcnl was associated with a less drop in hemoglobin, overall fewer transfusions, a length of stay that was shorter, and lower visual analog pain scales compared to standard Pcnl, and only operative time was shorter and favored standard Pcnl. So mini Pcnl preserves the stone-free rates of standard Pcnl while reducing the morbidity. So maybe reduced tract Pcnl procedures can compete with ureteroscopy for the treatment of medium-sized stones where ureteroscopy has been shown to not be that effective. Regardless of the procedure though, stone-free has to be the goal, and anything less really sells our patients short. So in summary, nearly all stones can be treated with minimally invasive procedures. Shockwave lithotripsy is best reserved for patients carefully selected by size, location, and composition. Ureteroscopy is effective for most ureteral and for small to moderate renal calculi. Pcnl is reserved for large and/or complex stones, but the threshold size for Pcnl is clearly decreasing. And finally, careful scrutiny of outcomes and honest reporting may ultimately change our treatment algorithms. So thank you very much. It's really been a pleasure for me to participate in this, and I'll send it back to Dr. Rastogi.